Hi, I'm Dr. Koerner, and I've got some colleagues here, and we'd like to take, I don't know how long it'll be, but it's talking about a case. It's a case where it's an upper first molar extraction, a surgical extraction that had the potential to be extremely difficult. And in fact, it was somewhat difficult. But before we get started on that, let me have you guys introduce yourselves. Andrew, why don't you say something about who you are, where you are, what you do.
Sure. My name is Andrew Drollinger. I'm a general dentist. I live in just outside of Houston, Texas, where I work for the state. I work for a facility that treats intellectual and physical disability. And probably about 50% of the treatment that I do is surgery. The rest is just basic general dentistry, and all of it entirely is done under general anesthesia.
How long did you work at a dental school?
Well, prior to moving to Houston, I worked for Roseman University for 5 years, full-time professor, assistant professor. And the majority of that time, I was in the oral surgery department full-time.
And you were over AEGD?
Correct, yes. Started an AEGD residency, was with that program for about a year and a half. And I was also director of orofacial pain for a time before I left to come to Texas.
So I think what we're looking at today mostly from you is your time when you were in the oral surgery department teaching oral surgery to residents and students. Mikhail, why don't you say something?
Hi, good evening, Dr. Koerner. Thanks for having me on board today. Mikhail Mukhin. I've been with Dr. Karl for the last few years, and our fun adventure was exodentia. Essentially, I'm myself as a general practitioner as well. I did most of my surgical experience with the United States Air Force. I did advanced training, just AHD 1 year program where emphasis was pretty heavy on the surgical experience, was IV sedation and third molars, and essentially the rest of the few years that I spent on active duty, I treated as a resident, so I did get to experience quite a few cases in surgical treatment. Essentially, once I got out, I've been working in private settings / corporate setting and do a lot of surgery, and essentially emphasis on comprehensive care was IV and oral sedation, and essentially helping out Dr. Koerner and learning a lot myself and expanding the experience and in terms of exodentia.
And it's good to have you both here. And I'm Karl Koerner, and I teach at Roseman now, and I donate quite a bit of time at Donated Dental in Salt Lake. But I enjoy staying on the faculty as an adjunct professor and being in there frequently to do cases with the students. And all three of us are teaching courses around the country for our center. So we can get on with it. So the purpose of this is to talk about the difficulty of an upper first molar. It's especially for doctors who want to help evaluate which ones might be hard and which are not. You can tell a lot of that from the x-ray. There's a lot of other things that we will learn about this tooth and how to make it basically a faster case. How can we get in and get out? How can we do it without complications? If we have complications, can we take care of the complications? And I'd like to see this more of a discussion than a formal presentation. And so as we go along, I would hope that we could all contribute equally and not just me or any one of us, and just share experiences and our knowledge. So I guess you could call it First Molars 101. Basically easier and faster. And the first, we're not going to read these words, but, it's all about good case selection, and case selection isn't just the x-ray, is it? It's how is this patient's health? What is their tolerance? Can we manage them, or do they have some things about them that would make it harder? And feel free to pipe in anytime you want. My experience is that about this is just my own guess, is about 80% of upper first molars would be surgical. And that is if you want to save the bone. If you don't care about that, maybe you just, you call them a non-surgical because the tooth comes out in one piece, but you lose the buccal plate. And a lot of the time, at least at Roseman, you guys, is for students especially, and not so much with established dentists, but it takes them forever, especially even a D4 though, to make the flap, if need be, whatever flap it is. It doesn't have to be big, and the section cut. Did you notice that, Andrew, at the school, that it just is sometimes hard for them to feel comfortable with section cuts?
Well, they're very uncomfortable because they just don't have much time with a surgical handpiece at all. And they want to remove the tooth using a routine technique before they approach anything surgical. And that tends to burn up a lot of time for them.
It seems like they'll go to great lengths to not have to use a handpiece, which means, can you do this kind of tooth like in the x-ray right there? Can you do that without using a handpiece? And I don't think so. But so what we would like to encourage is that whatever they do it quickly, and they don't take a long time doing it. Mikhail, when you're teaching, what do you teach in terms of how long you do something before you stop doing it and do something else?
Well, usually it shouldn't take more than a few minutes. And I think the biggest problem with general practitioners run into is, we have that emphasis in dental school that, we're going to approach that tooth routinely. And a lot of times people think like, well, if I'm going to approach that tooth surgically, it's going to be more involved. Patient might have more discomfort, but in reality, it actually reverse. It could be actually way more effective, efficient, and less painless. And on top of it, less problems with in terms of complications and healing process after the procedure. And I think that's where I think, in my opinion, a lot of people kind of misguided in terms. But that's my take on it.
Yeah, I agree. I worked with a student once that his purpose was to try to have it be a non-surgical extraction because it was a cheaper fee for his friend who was a patient. So he got it out in one piece, the first molar, broke out all the buccal plate, but he felt like he had succeeded because it was a routine extraction and the patient didn't have to pay as much. Go figure. When does that mentality have to change? Hopefully soon. So what I've done here is identified what I think part of these x-rays, some of them are from Nicaragua, and we taught a course down there with a patient course, but the arrows point to teeth that are not in the sinus. They may be to the sinus, but I would say these are intermediate level. I mean, they don't have quite the potential for difficulty as if they overlapped into the sinus like 7-8 millimeters or so. So, I think some basic surgical techniques of sectioning and that, if they don't come out, if they're not the 20% that comes out non-surgical, I mean, these should be pretty straightforward. Where things start going south is, really long, like this. Sometimes those roots, just by virtue of, how long they are and how tough they can be, how wide they are, they're round. So that's an advantage, but they're just difficult. So here's a couple more like that. At the lower left, we can see a couple of students and the oral surgeon in the clinic, and then on the other side, we can see this is a different tooth that goes with that X-ray, but we could see what happened a few minutes after using an elevator and a forceps. This was just using elevator and a forceps. And now we're way subcrestal on it. And this is where some general dentists might start to worry, but really, they don't. I mean, still the same, right? You're still going to section. You're just going to do it a little deeper. what do you start worrying about? Either one of you, what would you be concerned? And if so, what would you be concerned about?
Well, certainly if you're broken below the bone level, then your worry is displacement into the sinus. That's going to be number one. Especially if you're approaching this as a routine extraction, because that means that you're going to be digging and prodding and rooting around with an elevator or some other hand instrument with apical forces, and that's going to be what displaces the root into the sinus. So that would be the number one thing that I would be concerned for students to do.
I like your pun about rooting around. Reminds me of Dr.
Digging,
Monk.
scraping, and hoping.
Yeah, reminds me of Dr. Monk when he would talk about truffle hunting.
Truffle hunting, yeah.
Yeah. So here, the question I would ask is, what's going to turn out to be the most difficult part? This one has some potential issues with it, but of all the things that could go wrong or be difficult, what's going to be the worst? I mean, is that a glass half empty attitude? Maybe, and I'm not going to read some of these things, but I think those things can be powerful as they look at it later, because some of the things that we don't go over, the words, they can look at those and maybe glean something from that. So we're going to finish taking out the tooth shown in the x-ray just a minute ago. And by the time we get done, what I would say is if you can learn anything from this case, which is fairly difficult, then you can more easily do other cases which maybe aren't this hard. So there's nothing that says you have to go after the hard ones. This is an aside, and I don't think either of you, I don't know if I've mentioned it to you yet or not, but I was asked to evaluate this device for Gordon Christensen, and so they sent me one. And of course, I don't have my own patient practice anymore because I'm working in other places treating patients. Like we have our patient treatment course coming up. Wednesday night and Thursday night, I'm going to be screening patients. Andrew, you're coming for that, aren't you?
Yes, I'll be there.
I'll be screening patients for like 3 hours each of those nights in preparation for our course in Salt Lake, where those patients will be treated by dentists who flew in or drove in from wherever to take that 3 days of patient treatment, like I've taught in Jamaica before and in Nicaragua before. But here's what it is. That picture shows what it looks like. And that is weird looking, but it's magnetic. It's called a magnetic mallet. And this isn't a promotion because we're not getting a dime for saying anything. It's just something I was evaluating and I thought it was interesting. And that's the only reason I'm saying anything about it. No commercial connection whatsoever. But so as we use a luxator, but as we know, a luxator doesn't go very deep. But then we add the skinny burr. This takes the place of the skinny burr. But it's a luxator too. And what it does is it has, so someone said 5 Gs of magnetic force, of gravitational force would be the Gs, but something equivalent to that. And it drives something inside it to push that tip further in the socket. And this is the tooth that the oral surgeon I work with is going to use it on, and he's never used it before. It's his first time, but it has a bulbous root. And this is the kind, if you would ever expect a problem with the tuberosity, it would be this one right here. I mean, that bone is weak, that bone is thin, the root is huge, but he's going to drive it up the edges, and we'll just see how it works. So we've got 2 kinds of tips there. The tips on the left are, look how thin they are. They're just so skinny. They're, I don't know, 4/10, 5/10 of a millimeter. They're like sharp blades. And the ones on the right are not designed for extractions at all. They're designed for ridge splitting. And you can see how that might work. So these are the 2 blades up above, the close-up of them. And this is a video maybe it's not a video. No, that wasn't a video, but I think this is a video. So what this shows is how thin that blade is right adjacent to the tooth. You can see how skinny it is, which is, you don't see that very often. And then this is what it's going to be like to do it. And I think there's audio with it, just ambient talk. Now that click you hear is pushing a foot pedal, the rheostat, and that click activates that 5 Gs of force, and it pushes that tip. Every time that click goes off, it pushes it 1 millimeter deeper down.
What line? How far down that is?
Yeah. Laser marking.
That's pretty cool though. Like that's the case again.
It's controlled. Awesome. I think the biggest problem is just helping the patient get used to the sensation.
Yeah.
So that's what it's like. There's just another view of it. And here's one that came after as the tooth was being extracted. And this is the oral surgeon doing this. So all he's done is use that tapping on the mesial and distal, and now he's using a kind of a figure 8. So, and then here's another patient. I did this with a different dentist, and that arrow shows where the blood is on the instrument and how far down it was going. And I'll just show this to see the click again. And there's another one, but I don't think I'll show it. He's more aggressive with his clicks. He wants to get it done faster, but that's okay. So anyway, that's what it is. So have you ever seen that before or even heard of it before?
I've heard of a power tome that was pneumatic, almost like a little miniature jackhammer, but this looked like it was pretty smooth. It looked like it was comfortable for the patient. And it didn't seem like it was jarring or uncomfortable.
So the power tome, I had one of those. They went out of business. The factory burned down, I heard. And then Salvin came up with the Autotome.
Or the Autotome, yeah.
$1,500. And that is similar. So it's pneumatic, like a jackhammer taking out cement in front of your house.
Yeah.
And similar to this one, they don't heat up. So they're not like a piezo. You can do the same thing with a piezo. Piezos are $5,000 and they can burn bone really easily if you don't have enough water with them. So you've got piezos, you've got drills, you've got Autotome, and then this instrument. So it'll be interesting to see where it goes, and if people buy it. If you buy it just for the extractions, I think it's $4,000 or $5,000, and then there's other things with it. So with this case, I wrote some things down. We don't have to go through all of them. That'd be boring. But there are certain red flags with this course, and if someone's watching, you need to go over that and look at things that you would need to be concerned about. That just means you don't worry about them. I don't worry about them, but they're in the back of my mind. And whatever complication they might lead to, I just want to think about, I don't want to go there. I don't want any of those things to happen that as it mentions. One of them is that the older the patient is, the denser the bone is. And so that, of course, that's true. Here's something else I will show, but maybe not go through unless some of you want to pick out one or two from just looking at them right now and maybe comment. but these are some potential complications that could come from this procedure. Once you're experienced, these become pretty much a non-issue, like taking too long. I think any upper first molar as a surgical extraction, really, if you follow some of the things we talk about in this presentation, shouldn't take longer than 15 minutes. Do you have any feelings on how long you think a general dentist should take? You hear horror stories.
Yeah, I think, you bring up a good point. I think it should be a limited amount of time, but that's if you can identify that tooth should be a surgical extraction. If you should approach that right away as a surgical extraction and not try so hard to make it a routine extraction. But I don't know, 10 to 15 minutes, I would say, would be realistic.
I would say your goal, yeah, I agree, not to go any longer than that, and hopefully sooner. Mikhail, what do you think?
Yeah, I think actually Andrew brought a very valid point. I mean, I think it all comes down to pre-screening the case correctly. I mean, a lot of times, again, it could be an easy case by tough management of patient, but if we just emphasize it strictly to the extraction, if you see that there's multiple things that can go south, so to say, a lot of cases I don't even pick up forceps. I almost never use forceps except when I expand the bone and just literally elevate the tooth from the socket. But like case you showed right now, I mean, I know that, hey, that I have to suction, stabilize, and minimize the risk of displacement that root into the sinus. So, I mean, I think it's a very good perspective to emphasize to docs, especially who just starting doing this, is the biggest thing. You need to have appropriate x-rays and screen the case appropriately and make sure you're comfortable doing that and kind of anticipate a couple scenarios that can go wrong. And then if you approach that mentality, I think that will minimize the problems.
I think one reason I don't really feel like we need to go through all of these things is because we have a course for that. We have our Continuum 1 that both of you teach, and I sometimes teach in New Jersey this last week, teaching similar material. And, most of these things, the three of us will cover as part of the 2-day course that has models and then that has the 8 hours online before. So, we'll discuss these things like fracture the tuberosity. We don't fracture tuberosities because they're usually erupted upper thirds. And if they don't come after a certain period of time, which is very short, then we, on that one, will reflect the flap with the releasing incision. So that means it's triangular, and remove some buccal bone. And it's treated kind of like an impaction. But we wouldn't do that with the first molar. We wouldn't do that with the second molar. We could do it. We could get away with that with the third molar because implants are rarely there, and the root structure is not always like a first or second molar, more anomalous, and doesn't lend itself to some of the same techniques. So again, let's not go through all of that unless there's any that you want to comment on. Most of these things are things we've learned not to mess with or not to have happen, or if they do, it's not a serious thing. We can take care of it. So I'll go on. And this says, on the other hand, wouldn't you think about that avoiding or preventing a complication is equally, if not more important than having to manage them? So, we can avoid them, and if they happen, we can manage them. But I think it's better to avoid them so you don't have to manage them. And I think we would all agree with that. Again, I'm not going to go through this. All those complications I talked about. Here is a Reader's Digest version of what would be done to avoid it. So those are there. if people want to look at them. Mikhail, why don't you talk about high speeds? First of all, which one would you use in taking out this in terms of sectioning and doing the things you need to do? And then what do you think the average general dentist does if it's not what you do?
Well, I mean, first and most important, I mean, you do have to ideally have a surgical handpiece to minimize air emphysema, especially if you're like full mucobacterial release. And I think a lot of people kind of misguided and they try to take those teeth out with regular handpiece, and that's kind of, we need to kind of have a certain standard of care for that. You can use straight handpiece for that as well. I mean, I typically, for something like that, I'm fine using both. And in some cases, if I do multiple extractions, I'll have both handpieces set up actually for the case.
You'll have both handpieces?
Yeah. Let's say if I have a full mouth extractions, I'll have both handpieces set up. Because I've run into scenarios when one of the handpieces actually would stop working.
Which do you use more?
I think for like molars and like your surgical extractions, I'll use like impact air. For third molars, probably majority of the time I'll use straight handpiece. But if it's something more complex, I'll typically use straight handpiece. If
you could only use one, which one would it be?
For this case, I probably would stick with straight. But I think for a lot of general dentists, they like that fill up the same handpiece as your regular handpiece for routine procedures. And I think they probably would feel more comfortable with that handpiece.
In a minute, we'll talk about how the high speed, as good as it is, and we don't discourage people from using it, but there may be something with this case that would not allow it to be adequate, to get a root out, because it doesn't get deep enough where it might need to get deep. Andrew, I've got a question you can answer. I want you to tell us how to teach dentists not to use excessive force. You have any wisdom on that?
I think when you suffer through a complication, it's a better teacher than I am, and you learn not to.
You're saying they all need to break something before they learn?
I mean, yeah, that's how I learned. I think I've had almost every complication, and you certainly do learn, and you learn on a different level. I think you really don't want these complications to occur again. So I think teaching people not to use excessive force, I think it just comes back to evaluating the x-ray and appreciating what could possibly go wrong when you really drive your hand instruments apically.
I was helping a student once, and it was a lower molar. And so he was doing everything right. But he was at a point where he put a cow horn on the lower molar. And I said, no, that's a good instrument, but, loosen the tooth up a little bit. It may not get it out. We may still need a section, but see what the cow horn can do. And he took that cow horn and he jerked it buccally clear down horizontal and totally removed the entire buccal plate. And he said, is that how you're supposed to do it? And I thought, well, it's going to be a long year.
Yeah.
So, yeah, he just didn't have a sense of, is he going to do implants? Does he want to do implants? So does he want to, grafted bone isn't as good as the patient's own bone. It's better to save it. And it would have been so simple to loosen it a little with a cow horn. I do that all the time. Loosen it a little. But then when I sense that it's not, it's wider down there than it is up here, and it's going to have to be cut in half to get the halves out, then I'll just go ahead and section the tooth and not go the force route.
Yeah, and I think also important things to add in terms of, you kind of almost have to fill the tooth. If you don't feel any movement, there's no necessity to put that force on. And I think that's where, like Dr. Drollinger was saying before, people just want to use forceps more. And if it doesn't move, you want to put more and more force, but that's a mistake. usually, in my case, I don't feel a tooth movement was elevation, any forceps that. Then I typically don't even waste my time on doing the go to surgical approach right away.
I like what you said. If you don't feel the movement with the forceps, then you don't use the forceps. You do something different. If you don't feel a little bit of movement with the forceps after a reasonable time, then you don't use it anymore. You do something.
Yeah, and in reality, it might sound initially aggressive, but in reality, it's more effective, more predictable, and actually less traumatic to the patient.
Right.
Yeah.
You know, when I ask general dentists what burrs they use, I'd say 9 times out of 10, the burr they use for sectioning is a 557.
Yeah.
Do you think that's just because that's a common burr for general dentists? And
It's what they have. It's what they use.
It's what they have.
That's what I think a lot of dental schools kind of pushing, I'd say, at least from my experience. I mean, I'm sure it's different in Rosamond.
No, well, yeah, we at least when I teach them, I say that's too skinny a burr, and for what you're trying to do and accomplish, and that's not going to do it. You need to have something just a little bit wider, and the 702 is half again as wide, and it matches with the 301. You could put it 301 in the skinny way, turn it and hold it, and then hear the click. What burrs do you use for section cuts? And one of you might say a 557. I don't know.
I use the 702 for the majority of the surgical extractions, and I reserve 703 for wisdom teeth, lower wisdom teeth.
When do you go the other way? When do you go the other way for 701?
And then 701 when I have limited space between adjacent roots. Yeah, or anterior teeth. I'm really, really trying hard to preserve bone, buccal plate, and that.
Or maybe at PDL troughs.
Mm-hmm.
Yeah, and again, a lot of times it's personal preference. Like I have for straight handpiece 701, 702, and the majority wisdom teeth, and then for more complex cases, I still use 557 once a lot of times for just routine surgical extractions. And again, I think it's a personal preference, but 702 is probably the majority of the time that's going to be.
So when you use a 557, do you try to keep it the same size as the 557?
No, I usually make it wider, and again, because I use my Cogswell A, that I think that kind of almost hybrids it in the situation a little bit, because the tip is kind of skinny. But again, I'm a little bit of a rebel in that aspect.
Well, and we'll let them go to your course to hear about your Cogswell A. Let's see. Oh, what is this? Yeah, I think these are just simple things, like when you're using an elevator on a tooth, when you see the adjacent tooth move as much as the one you're trying to remove, that's a big red flag.
That's a big red flag.
I mean, that's why God made interseptal bone, is so that we would have something to fulcrum against and not the adjacent tooth. I mean, I'm sure he thought about that. And then, of course, if there's any kind of a restoration on an adjacent tooth, I wish I had, a dollar for every time that I've told the student not to use the elevator there because there's a crown, like a gold crown or a PFM or a ceramic crown next door. And as soon as I walk away to help someone else, then they think, oh, what does he know? And then they do it. And then I come back and the crown is broken, or they have to run up to the 4th floor and get some cement to re-cement it. It reminds me of my kids. But anyway, that's human nature, right? That's human nature. It'll work for me. It didn't work for him, but it'll work for me. I like the 88 sometimes because you can get underneath a tooth that's all bombed out, sometimes find something that it'll work on. Let me ask you this, and I don't want to, if you don't feel strongly like I do about this, it doesn't matter. You tell me what you feel. But if you had a first molar you had to remove that has a mostly intact crown, like some decay went to the nerve, a little bit of decay went to the nerve, necrotic pulp, they don't want endo, they just want it out. You know what I mean? Would you section that from the occlusal into the furcations, or would you cut off the crown first? And if you don't do it the way I do it, you don't hurt my feelings. It doesn't matter, because I respect you, and it would mean you have maybe something I can learn from you.
I don't think it really matters. I think that if you try your section cut from the occlusal approaching apically, you're probably going to break that top component of the crown off anyway, so if you decapitate the crown off like you show in this picture, then it's going to give you more room to work and a flatter surface to approach your section cut. So there are benefits to it. So
what you're saying is, if you go from the occlusal, that's just a faster way to get closer to the furcation, because all the ground's going to break away. It's less predictable, but you're probably going to end up basically with the same effect. Yeah, and I think you're right, because it's happened to me many times. So what do you do, Mikhail?
Before I started working with you more, I would just go strictly from occlusal, and again, it works for me fine in a lot of cases. But I think if you start doing it from you don't have as much surgical experience, I'd say it's more predictable if you section the crown off, because it gives you more visual orientation of the pulp chamber. And let's say this particular case, but that the furcation is right pretty much with sinus proximity, that, hey, you visualize a pulp chamber, that if you're going to make your section cut, you don't want to go too deep because you're going to perforate the sinus. Versus, if you go from occlusal point, you don't have that information, number one. Number two, you have to be really good at orientation then. And if you have that skill, kudos to you. But I'd say in the beginning, in my opinion, from what I've seen and experienced, I think it's more predictable if you cut the crown off, just because it gives you more visual information.
But I like what Andrew said. The bottom line is you're going to section, okay? And all this stuff that happens before you start sectioning, to get part of the crown off so you can be closer and all that, you're just getting to the point that you have to make those section cuts. So whatever is easiest for you. And this is one way. It's just one way.
And what I found, if you section from the top without taking crown off like you do, you just end up almost like at the same step, except you have, broken parts, either buccal or lingual.
So with this case that we're talking about today, this ended up very soon. So there was a little elevator, and then the forceps really couldn't get on it because of the lingual part there that's so decayed down subcrestally. And there was a palatal, no, there was a buccal side. That's the buccal side that's left. There was the buccal side went clear to the occlusal. When he used a forceps, he fractured that off, and here's where we end up. And this is the point at which some general dentists might get a little queasy. Well, what's the bottom line here? What's the next step? And is it that difficult? What's the next step here?
I mean, it could be one of two things to approach this extraction at this point. One is we could raise the tissue and get us a little better visualization of the buccal plate and where the bone and the tooth intersect and that where that border is. Or we could just go ahead and make the section cut and see how far we get with that.
Yeah.
But it's definitely going to be a surgical extraction. There's no point in using a 301 or any other hand instrument to pick and try to pry this out. It's just not going to work.
Yeah. But some people will do that just because you've still got three roots going in three different directions. And what is a root tip going to do about that? Nothing. So to cut this, what you see there, in half, you got the buccal roots on one side and the palatal on the other. At some point, you have to get those separate, right? You have to get them separate. And here's where people would start worrying about that decayed down part of the palatal root, because, and especially if there's pathology at the apex. If there's pathology at the apex, that means there's no stop at the apex. And whatever you use to try to tease that root out, if you put any apical pressure, if there's no stop there because of the pathology, then you're going to help the process of pushing it in. So this is where I would think about engaging my headstrom file as like going to State Farm and buying a policy, for not having that go in the sinus and need to be referred for a $2,500, flap procedure, a buccal advancement flap to try to get primary closure. We don't need to go there if we're cautious, not trying to get it out, but doing something to prevent it from going in. I think we can not talk about that. See these things. Okay. Do you have the same problem I do with the mesiobuccal root as being difficult just because it's a double root and has vertical indentations on it? Do you do what I do to help get that one root out so I don't remove buccal bone as often? Or do you not worry about, is that not an issue with you? I sometimes obsess over things, and I don't like to think I'm OCD, but maybe I am a little bit. What would you do from here? Mikhail, what would you do from here? Just give us three steps.
I do like to have a little bit more visualization in those cases, especially if it fractured like this or it presented like that. I would reflect full mucoperiostral release so I can get more information. First of all, to see what the thickness of the buccal plate and if there's a defect to begin with. Second, then I would, if I would reflect the flap, I would see if I can get any mobility was just simply elevating him a little bit. Sometimes it does come out pretty routinely, but most of the time that's not the case. Then I would make my section cut between mesial and distal root, separate them, remove them, and then depends on the palatal case. Again, if there's periapical pathology, you can stabilize it with the headstrom file just to minimize the risk of displacement at the sinus. And if there's no mobility, I sometimes would take like molds and sometimes wiggle around the root, and sometimes you can slide it in the PDL space and it would elevate the root. If not, you can put a little bit of troughs then on either mesial or distal aspect and just respect the anatomy in terms of sinus proximity.
So you would reflect, lift up those papillae and reflect a little bit of buccal tissue, reflect back the periosteum to see a little better.
Yeah, either horizontal or even in some cases, I'll just go ahead and do vertical release.
Yeah. It's really hard to miss the furcation on the buccal. If you flap it a little bit, a couple millimeters at least, and you're looking at the furcation, it's hard to miss it, when you reflected a little bit of a flap and you can see that hint of it where one root goes this way and one root goes that way. And that's where your burr is going to go. And you're going to go, coronal from that. And then you're going to put your elevator in there. It's really hard to screw that up,
yep.
If you have a little bit of a flap.
It's a great reference. And, let's say if you don't do a lot of endo or surgery, I think to begin with, that's a little bit of a challenge for you, unless you're an expert in anatomy with, variation of teeth. But I think in terms of giving you more information with visualization, it's very important. Same thing with good suction. And at first I would actually irrigate it really well and inspect it with light and see where I'm at.
But you're definitely going to have your palatal root separate, totally separate from the bones.
Yep, that helps quite a bit.
So my obsession is sometimes with that mesiobuccal, and occasionally if it doesn't come and I'm afraid I'm going to use enough force to maybe, break a big piece of it off, and then I'll be even deeper down. Sometimes I'll take the skinny burr, like Andrew was talking about, and and kind of make a U around that without letting it go through the buckle, and go down about 6 or 7 millimeters in the PDL, and especially if there's room between this root and the tooth distal to it, or mesial to it. So, I'll use that on to go around that mesial buccal root just to free up, and it makes it so if there's any bend on it or grooves, vertical grooves on it, they don't have as much impact for difficulty. I took this one just last week. So what I was doing is I was having this student, the one with the glasses there in the left picture. She was making the very cut we were just talking about. She was going between the buccal and the palatal, deep into the furcation without going so deep that she went into the sinus, just enough to put the elevator in there and click and separate to 2 halves. But I could not get her for the life of me to go in the right angle. She was going like 45 degrees in that. She was either going into the palatal, she was mostly going into the palatal from where she was standing. That was easier. And I kept telling her, straighten it up, straighten it up. And she didn't know what I meant. So the student next to her grabbed the handpiece and pulled it over and said, like this. Fortunately, it wasn't running at the moment. So no harm done, but she just couldn't get it. And I wonder how many other dentists that are learning don't get it. We're talking about vertical here. We're not talking about 45-degree angle. But then she did finally get it, and she used a luxator, and I complimented her that the luxator was vertical as it normally would be. This one bothered me because the handpiece is, look how much of the lip it's resting on. Would you comment on the pros and cons? Are there any pros? You want to talk about that, Andrew, and what potentially might happen being that far up on a handpiece if you're using it?
Well, you have a lot less stability for sure, and you're not in control of the instrument. 2, if you're focused on the working end of the burr, the lip could be resting against the shank of the burr and burn the lip. And that unfortunately does happen, well, occasionally with students. So you definitely have to be aware of that. There are burr guards in that, but some of these straight handpieces don't have very good burr guards.
Well, that's on the right. That's a burr guard on a Bien Air.
Yeah, that white plastic piece is the burr guard. Yep.
And the Strikers, though, is like twice as big.
But even still, if you're not paying attention, that lip can slip up there, and before you know it, you've got a burn, and they can be pretty significant.
So I have that picture on the right. It's from our third molar video that we use before we have people take out the lower third. But it shows that your finger rest is close. You're holding it close. You're in better control. You're doing your buccal trough. You're ready to section through the tooth towards the lingual side, but you're right in there. To have it way out like that, if we don't tell them, who's going to tell them? Once I was using a straight handpiece, and it was touching the lip a little bit, and it shouldn't have been. But the bearings were going out, and the handpiece heated up, and it actually put a burn on this lady's face. And by the time I noticed it, she had like you work in the yard and you get a blister on your hand. She had a blister on her face caused by the heat. And you don't ever do that again if that happens once.
Yeah.
And then you hopefully I've taught enough people not to do that. It compensates for that one mistake. And then we already talked about a headstrom file. This is the berry tooth that we've been looking at in the x-ray. And you can see how far down, at least halfway. And you see the 2 empty buccal sockets. And that tooth, I'm sure that root, it's one that overlaps the sinus like 7 millimeters or so. And I'm sure there was a high probability without using something like this, it would go in there. But one point I wanted to make this happened to Dr. Miller on a case just like this on Tuesday last week. So he was doing this exact same thing, helping a student, and he couldn't get that root to come out no matter what he did. And to be honest, he didn't use the headstrom file. But what he did do is he took the skinny burr, and because he couldn't get that root to move, he took the skinny burr in the PDL of that root and went down deeper, like halfway of the remaining root. And then he put a luxator in there and twisted it laterally, not apically, and was able to loosen it up and finally get it out. I held my breath. I mean, if it were me, he knows so much more than I'll never know that much. But, and if it went in the sinus, he could handle it really well too, because he's an MD DDS, but he knew what he was doing. And he knew he'd get a good outcome. But what I do personally is I want to have a little more insurance on my side to help protect against something that probably won't happen, but could happen. And that's why I will use it. So the winner at the beginning, we said, what is the most difficult part of this procedure? I think the most difficult is that root that's overlapping deep into the sinus or the wall of the sinus, and that it's deep in the socket, broken off into the socket as well. To get that out successfully and quickly, not take forever, and not be sweating profusely. That's probably, for me, that's the hardest part of this. What's the hardest part of this case for each of you? What in doing it from start to finish, what would be the one that would, if anything, what would worry you the most?
Well, for me, I think it was I can't remember if it was mesial or distal. The proximity to the adjacent root was very limited.
Yeah.
That is, for me, the biggest challenge, I think, just trying to preserve that bone and not cause a complication for the adjacent tooth.
Like with your distal mesial section cut, for example.
Yeah, and if I need to do a U-shaped cut, like you described before for the mesial buccal root with a skinny burr, if you have a very thin piece of bone between your two adjacent roots and you strip that bone away, now you have problems for the adjacent tooth.
And you could strip it away from pressure, like fulcruming with the luxator and pressure necrosis.
That's a good point. Yeah, digging and prodding. Mm-hmm.
You don't have to drill it. It could die anyway. And so here's the headstrom file on that root that was way down there coming out. So this is a different case. This was nobody's fault. The first molar was removed there on the far right lower, and it just, I think it trapped a little bone between roots, so it was like pinching the bone. And as the root came out, nobody's fault. That happens. You get a 5 millimeter perforation. And so to treat perforations, do you do this in your office now, Andrew? I know, is this a thing you do or not so much? Do you use collar plugs or do you use this bone graft osteogen?
Well, both. We do both, but collar plug is something that we use routinely. Osteogen plug, we'll use that also, especially with some sinus exposures.
I think the collar plug is like the standard. And then using osteogen, if the government or your corporation or you want to pay, it's like 5 times as much money.
Yeah.
So like from 10 to 50. So if there may be an economic issue.
Yeah.
They both work. This may work a little better just because it's a bone graft. It has 50% alloplast in it. So it's a good way to go as well. And then I think this is the end of it. And this just shows the pre-op X-ray. And then there was a flap that exposed the edges of the bone, maybe a few millimeters. and the papillae were definitely lifted up. And this shows the cross horizontal mattress over the osteogen plug, and this should heal fine. And so if somebody could were able to listen to this and do some, if not all, of these things, or have access to those as ideas and exposure to those things, I think it would just make them faster and better. So in closing, do either of you have any final comments to make on a case like this? Things that would help someone right out of school, or maybe someone 10 years out of school, to make this a more routine, less worrisome procedure?
I think the only thing that I would say is I think this is a great case to really look at and make it a goal to learn how to master, because if you can do this tooth, you can do pretty much all the teeth. Approaching this as a surgical extraction, not wasting time on a routine extraction, and then overcoming any hesitations that you may have with sectioning a tooth and raising a flap. I think those are the two hurdles that we see commonly with general dentists and students and residents.
Yeah, my main thing I'd say in the beginning, if you don't have as much experience, is know your limitations, number one, know when to refer. And the challenge is to take courses, get better, and just, get to the point where you look at that case and say, hey, this is what I'm going to do if this happens. This is what I'm going to do if that happens. And I know I can do it pending, medical condition and patient management. So that's my recommendation kind of on that.
Well, I don't think there's anyone better than you two to be able to teach that 2-day course, with the additional online and go into depth, with these types of things and other related things. And so, Andrew, you said if you can do this tooth, you can do almost any tooth. So we're not talking about just first molars. If you can do this case, you can do other first molars. If you can do these things, they represent principles that are applicable to a lower first molar, or to a canine, or to an upper first premolar, or anything you might want to do. All right. Hey, that's about it. Thanks, you guys. And we'll make this available to people and hope that they can benefit from it. Appreciate you being here.
Thanks.
Have a wonderful night. Thank you.
Bye.
Okay. Well, I think it went well. I don't think we need to edit anything.
I think you did great. I think it was an excellent case. I think it's really, really good case to look at. It represents every fear that I think general dentists have. Yeah. And, it'd be nice if in dental school they got more, but it is what it is. They're preparing students for boards. You can understand that. And they don't have no
to take
code
out
requirements.
You don't take out a canine on a state board. So, that's where their time goes and their emphasis goes. But on the other hand, patients really want them to do this. So, all right. Thanks for doing it, you guys. And we'll edit it up and I'll send you this if you want to use parts of it, anywhere along. Or if we can maybe offer it as a promotional for something, I don't know what we'll do, but certainly if the first use for it would be if you want to use it for something.
All right.
Yeah, and I think for promotion videos, I think it's important to emphasize again. I mean, this is the case where there's no reason that GPs shouldn't be doing, but this is how we teach you how to mitigate problems and teach you how to screen those things. And again, I think also it's very important to emphasize that, hey, you don't feel comfortable doing it, just don't do it. Learn to get better, and then once you feel that confidence, then strive for it. I mean, I feel like that's where a lot of general dentists get burned. They go take a class and then they're all excited and they come in and take something they shouldn't take, and then they get burned and they just don't have desire to do it anymore.
But just because they prefer it because they don't feel comfortable, that doesn't mean they're stuck in that position for the rest of their career.
Right. Exactly. Yeah.
Because they're going to learn from every case a little bit and from every course a little bit. and they should be growing and progressing. They may have a associate, a mentor. You have an oral surgeon that you work with, that helps you once in a while. So we continually learning. And every course I teach, I learn something in that course. To either add to the course or
Yeah, true.
And every time I go to Roseman, I learn something. Just little things, but they help.
Mhm.
Okay, talk to you guys later.
All right. Good night.
Bye.